in order to access them if it's appropriate for you. And, because of that, I might not cover as much as you were hoping for about the newer treatments, but I do think you need to make sure that you're in pole position to access them if you're at that stage. So this is, what you all know, how disabling migraine can be, the fact that, it affects so many aspects of not just the head pain, but everything else that goes with it. And it has a real significant impact on life. You know that more than anyone, but, the World Health Organization recognizes that and has done a lot of work to try and really emphasize, the disability associated with this. And I think that's been very important. The Migraine Trust and other patient advocacy groups, the World Health Organization emphasizing the disability has really enabled us to perhaps pay more attention in terms of the newer treatments coming through, which are more expensive, but recognizing that if they can, make a significant impact to life, then definitely we should be trying to ensure patients are on them. So you'll know you'll have tried everything, and that's what you will feel, that you've tried everything and things aren't working. So what I want to do is think about, well, what are we expecting from a treatment? And obviously the holy grail is that you would take something and it would all be gone. But unfortunately, that's never going to happen. So this is from 1863, and I can say that, in 2050 or in 2099, we're still not going to be there. And that's partly because migraine is part of our genes. I have migraine. All of you who are joining us have migraine or have someone affected by migraine. And it's not something that we can just switch off. But what we really want to do is really improve, how those attacks are affecting us. So really to try and limit them. So, ideally to reduce their number and particularly their severity. And when we think about treatment, we think really about three main areas: behavioral and lifestyle. And I'm not going to talk about that today, but there's also the aspect of when you're in that migraine, what can you treat at that time to influence it? And what can you do to try and prevent more attacks from happening? And those are the two areas I'll be focusing on. Now, as a doctor, I think of the, treating at the time as acute abortive treatment, and obviously trying to treat to prevent them, I think of as preventative treatment. Some of you will have aura. Some of you will have aura, and the most common sort of aura is visual aura. So these are just pictures of what people have described as seeing. And obviously, some people get lots of flashing lights in a sort of like a halo, which expands across their vision, and then it just disappears. And sometimes in its wake, it can mean that you can't actually see for a short period of time. Unfortunately, we don't have a good treatment for aura in terms of the acute phase. So I think when you're thinking about acute treatments that we have available now, it's really thinking about when you've moved on to that pain stage. Obviously, this is an area that will be evolving. And there's some of you who find the aura quite disabling, because if it doesn't allow you to see, or you get some of the other aura symptoms, clearly you'd be looking for a treatment. But what I'm going to focus on is when the pain starts, what should you be doing? And this is what you should be doing already. So we know that when the pain is there, you've got to try and figure out, well, is this going to be just one of those headaches that I can manage, or is it going to morph into, the migraine beast, the really severe episodes? And for some of us, it is very hard. It's very hard to know, actually, is this going to, in 5 hours, be something completely different? If you know that it's going to be that terrible event, then you want to be using something which is very migraine specific. And hopefully you all are using a triptan in that case, unless there's a reason why you can't use them. So if I had a severe migraine, I would be going straight to option B, which is a triptan. And actually, if I did that on a couple of episodes and it never really managed to tame the beast, then I would be going to option C straight away. So I would take something like rizatriptan. I would take a lot of aspirin, usually 900 milligrams, or ibuprofen, 600 milligrams. And I'd also take an anti-sickness drug. My favorite is domperidone, just because it helps empty the stomach. So it really makes sure that the drugs that you're taking are absorbed as much as possible. However, if you have something which is a milder headache, and well, I haven't taken much in the way of painkillers, this month, and I really do need to function, then you may just be able to manage it with ibuprofen, and that may be all that you need. Now, one of the things that I'm often told is I've tried everything acute, nothing works. What's new? And I think we've just got to remember that the triptans are not the same. So although we say they're this group called the triptans, all of them are slightly different and behave differently in different people. So those are the 7 triptans we've got. There isn't an immediate new one on the horizon. And I would always say, make sure you've cycled through all of them to really get a sense of what they do for you. The other problem is that if you're vomiting, taking a tablet is going to do very little because you're just going to vomit it straight up. So sometimes things don't work simply because we've not got the right route. And this is an injection. And obviously, if you're vomiting, the injection will still get the medicine into you. So that's the other thing to think about. And we're always wanting to treat early if we can, to use the right medicine, to use the right dose, to make sure we're using the right route. So should it be oral or should it be an injection or a nasal? And always to use cautiously, because you will have heard about medication overuse, and that really refers to painkillers. And for some reason, migraine brains seem very sensitive to too many painkillers. And actually, if you're using too many painkillers on a regular basis, month on month, it will ramp them up, or has the potential to. So 10 is the safe number. And actually, if you're having to reach for painkillers on more than 5 days of the month, you should definitely be on a preventive. But, what can you do if you came to me, what would I be looking at to see, are you ready for any newer treatments that are coming along? Well, I think it's keeping a really accurate record of your exposure to different medicines. So this is a patient I saw, and the questions that she needed to ask herself and document is, what medicine am I taking? She took sumatriptan. What was the highest dose I used? She used 50 milligrams. How long did I use it, or how many attacks did I treat? She treated 12, which is a good number. Any side effects I got? Not really. If I treated 3 attacks, how many would my symptoms have resolved at 2 hours? Well, actually, probably less than 1 out of 3. So that's, something to think about. On average, at 2 hours, how much would my symptoms have improved by? About 50%. So, not getting rid of them, but having some impact. Was the response to treatment still there at 24 hours? Well, actually, no. Her headaches always came back. And actually, what is the most bothersome symptom in her migraine episode? And for this patient, it was sickness and vomiting. And actually, it rarely affected that most bothersome symptom. So as a doctor, when I've got that information in front of me, I can say, well, can we just say, right, we've done sumatriptan, move on? And the answer here is no, because actually sumatriptan 50 milligrams doesn't work in some patients. They need to go up to 100 milligrams. We know that the most bothersome symptom is vomiting. So she's probably vomiting it up. So if the 100 milligram tablet doesn't work, then she should consider a nasal spray or injection. And then we have to consider that actually she's just going in just with that triptan. I told you that when things are bad, go in with your guns blazing. So we could consider adding ibuprofen and the anti-sickness agent. And if she's done all of these and it still doesn't work, then I can put a cross through it and we can say, right, we need to go on to the next triptan. So you've got to have that ready when you are saying a medicine doesn't work. Collect as much information, and actually remotely. I don't need to necessarily see you. If I have that information, I can immediately plan, your next treatment. So it's really empowering. In terms of what's new and live in the UK, well, I think probably the main one is the sumatriptan 3 milligram injector pen. Now, that doesn't seem, that, sexy, because we've had the 6 milligram injector pen around for some time. It is really used in migraine when you have a really abrupt onset and you get to that peaks, almost, immediately, or you're vomiting profoundly. And there always has been some resistance in primary care to prescribing them because they're costly. The 3 milligrams is slightly cheaper, and it is as effective as the 6 milligram in migraine. And we think that the adverse effect is probably reduced. I have to say, at the moment, we haven't had that much experience in terms of patients coming back to us using these, particularly in migraine. So I think, you just need to know it is there. And if you are a vomiter, you should be asking your GP whether this is an option. Now, what about what's on the horizon? And I've talked to you about the triptans, but there is another new group coming through. In fact, there's another 2 new groups coming through. And the one that I'm going to talk first about is something called the Ditans. And the Ditans only have one drug in that group, and that's called lasmiditan or Rayvow. Now, obviously, in the States, they're always ahead of us. So, all the, the things on the internet are likely to be from the States where this drug is, being used. NICE, which is the group, our organization in this country which reviews these medicines, is looking at this, but we don't know when that result will be through, and it's not, we're not expecting anything certainly until next year. But why is it so interesting? Well, I think the key thing here is obviously it's nice to have something new in our armory against migraine. But for those who can't take triptans because of vascular issues, and by vascular issues, I mean maybe you've had a heart attack, you've got angina, or you've got very bad blood pressure issues, then this is something that is a potential opportunity. It's also something which, if you don't respond to a triptan, it may be something we could consider. It does have some side effects. So I think dizziness, sleepiness, feeling tired, those are the principal ones. And unusually, this one does carry a sort of like a warning that you can't drive or operate machinery for at least 8 hours after taking it. So that may limit its use in certain patients. And obviously, because of that sleepiness, if you're on other medicines that can also cause sleepiness, then that's not a good combination. But what does the sort of like data show us? And I'm going to try and keep it as simple as I can, but I think it is helpful for you to see, what we are seeing. So when I think about an acute treatment, something that works really well, I look at, well, how many patients are pain-free at 2 hours? That's sort of like a golden outcome. And what I've done is I've taken 100 patients, I've grouped them into this circle, so that's 100 of you. I give you a sugar pill, and actually, if I gave you a sugar pill, 15 of you by 2 hours would get better. So that's partly because sometimes migraineurs, have shorter attacks, even though we talk about it being over 4 hours. Some migraines are very short, but there's also this idea that we have a placebo effect, and we've always got to take that into account. Placebo is good because actually, if we're getting better at the end of the day, that's all that really matters. But if we then give you lasmiditan, what you can see is the number of people who are pain-free at 2 hours improves significantly. So, the bottom line is about 1/3 of people are improving at 2 hours. And that's not just improving, that's pain-free. And I'm not talking to you, I'm not showing you the data about being pain relief. And obviously the number of patients who experience, good pain relief is much higher than that. The next group of medicines, and again, we're very much at the moment thinking about acute treatments, are the gepants. They've all got really bizarre names. I don't know where that one came from. But the gepants are also the next kid on the block. So we've got rimegepant, ubrogepant, and atogepant. And you can hear and see the gepant throughout. 2 of them are, in the States being used. And rimegepant, there's probably some newer, exciting data on that one, which I'll share with you in a minute. Side effects with these, it tends to be feeling queasy, feeling tired, and a dry mouth. And if we take, we're going to take rimegepant, and again, we're thinking about how many would be pain-free at 2 hours. This is our group of 100 who've not yet had any treatment. If we give them a sugar pill, so that's the placebo, you'll see a small proportion will respond to that. But if we then give them the rimegepant, 21%, so there's a chance of 1 in 5 of being pain-free at 2 hours. Now, rimegepant is the one that I'm, talking most about, because whilst we think of it as an acute treatment, it is probably the first acute treatment where there's data to suggest that regular use is not harmful in the way that we see with other painkillers, but may also prevent the migraine. We need this to be, reproduced in other areas, but patients actually were taking the rimegepant on alternate days, so in essence 15 days of the month. And rather excitingly, those who did saw that you know, about half of them had a 50% reduction in their overall migraine days. So this is one that we are waiting, you know, to really see how it evolves, because whilst I've labeled it as an acute, you can see that its preventive role may also be quite key. So what else is out there and relatively new? And I have to say, you know, relatively new. I mean, I think these things have been there, but it's not necessarily things that you know about. And these are self-funded stimulators. And the stimulators have not had the same wealth of evidence, because the number of patients they try them in is much, much smaller. And so it's not always easy for organizations like NICE to make a very positive verdict and suggest that these should be funded through the NHS. So at the moment, they're not. So you would have to self-fund these. And I'm not going to talk about the evidence base, because I think it's quite hard. I think our experience is that some patients do find benefit. When we look at the studies overall, there is, you know, enough to support their, for you to be sitting in my clinic and for me to say, actually, you know, if you can afford it and you want to try it, then you should. The big advantage of all of the stimulators is you're not taking any drugs. So the side effect profile tends to be a lot kinder, because it's just about the local stimulation. So the Kefali stimulates the trigeminal nerve, or the supraorbital and supratracheal branches. And by doing that, it sends signals back to where your pain generator is, and hopefully it dampens everything down. You can use it acutely, and it's wearing it for about 60 minutes. And we always encourage you to use it at night for the preventive program. And sometimes it does help with sleep onset. It does cost, so you're talking about a couple of hundred for the device, and then, you know, a couple of hundred per year for the electrodes. The transcranial magnetic stimulator, this, you know, did have some evidence. It's a little bit more difficult to access. So whereas Kefali, you can access it, you can go to the site and you can actually order a Kefali device. This one is a bit more tricky. It costs a lot more, so it's about £200 a month. And at the moment, you need a prescription, so you've got to find a prescriber. It had problems. So it had problems in as much as there was a period where it looked as though the company was not going to be able to continue. But it is starting to pick up again, I think. So that's something to consider. It's short. So you hold this device at the back of your head, couple of pulses. It's a magnetic stimulator. So it's a sort of like a magnetic field creates an electrical pulse across the back of the brain. You do the couple of pulses at the start of your migraine, and then you can treat every 15 minutes if you need to. It's quite a loud noise, so that's my experience of using it, but it's otherwise, you know, it's completely painless, and it's quite quick to deliver. There are some other self-funded stimulators, which will be coming hopefully to the UK. So I know Relivion, you know, is looking at that, looking at coming to Europe certainly this year, and that I think will be, you know, again another positive thing in our armory. At the moment, costs, you know, they haven't yet declared that, but this is a device which stimulates not just the trigeminal nerve, but the occipital nerve at the back. So it's a sort of like a whole stimulation, if you like. You wear it for about 45 minutes. And the initial trials in patients who had, you know, what we call episodic migraine, which means you migraine on, you know, certainly less than 15 days of the month, it was very encouraging. So here, almost 1 in 2 were pain-free at 2 hours. And in the ones who didn't actually get the active treatment, it was 1 in 10 who were pain-free. And pain relief again was good. So I think it will be interesting to see how that evolves. And then the other one is Neurovio, which is the remote electrical neuromodulation. And it's a little thing that sticks on the arm, and it effectively is a way of modifying pain remotely. So it's active, it's not painful, but again, it's sending signals through our nervous network to our pain center and modifying it. It is a 45-minute treatment. When you buy the device, I think there are 12 loaded on there. And once those 12 are done, it's done. And at the moment, as far as I'm aware, we haven't yet got access to it. So it will be interesting to see how that evolves. So I'm going to now shift on to preventive treatment and try and ramp up the speed. So you will know that in terms of preventives, we've been very focused on oral tablets that we can give you. And we've been, using oral tablets since 1959 to date, and they will always still have a place. All of them, apart from methotrexate, have actually been repurposed from other medications we use to treat things like blood pressure, epilepsy, or mood. Unfortunately, methotrexate is no longer around. It was a very good drug, but there were potential problems with it, and so it was actually removed from distribution. BASH, which is the British Association for the Study of Headache, recommends propranolol, amitriptyline, topiramate, and candesartan, so those in yellow, based on the evidence and also the tolerability. The other ones work, and they can work very well in certain patients, but sometimes it is the issue of tolerability. And one of the key things is, the minimum dose that you need to try for 3 months before saying that drug doesn't work. And this is my experience, and this is why I'm going back to basics, because I think I see so many patients who've tried very low doses of things, and they haven't been stopped because they're not tolerating, but there's a sense, well, they're just not working, so move on. And this is where you will not be in pole position for the advanced therapies until we can be really sure that they haven't worked. So propranolol, I look for people to have been on at least 160 milligrams, amitriptyline at least 70, topiramate at least 100, and candesartan at least 16. And if you come to me and I've got evidence of all of that and they're not working, then it's easy to then move on. And you know that we've got these other injectable options for prevention on this side. And obviously in the future, it'll be a question of the role of the GPANs. So you need to put yourself in pole position. And part of this is making sure that you keep a log of any preventive medicine that you're given, actually, what the nuts and bolts of it. So this is a patient who took amitriptyline. They took it from January to February 2020, so that's important. Already I can say that she hasn't taken it for long enough. She started at 25 milligrams. Many patients won't tolerate that, but that's what she was told to start at. And in fact, she never got beyond 25 milligrams, and she stopped it after 6 weeks because she was so sleepy. And at that time, she probably was using more than 10 painkillers a day. So all of that information is important because I can immediately say, well, actually, we didn't really get to a dose that probably, could have affected the migraine. It wasn't taken for long enough. She didn't tolerate it. And that may have been because she went up too quickly. So I have some patients who are going up 5 milligrams or 10 milligrams, not at 25. If tolerability was a real problem, the sleepiness, she could have tried nortriptyline, and she may have found that she could, increase that one better. And obviously, you always want to try and make sure that you're not overusing painkillers at the time. The other top tip, which I'm sure you're all doing because you have come to a Migraine Trust event, is also to do your headache diaries. And every consultant will have one that they prefer, but the Migraine Trust is a great diary. So start with that and then work with whoever is in your local area to see what diaries they want. In the UK, if you have actually tried 3 of these preventives really well, as I've already outlined, or my local agreement is if you've tried 6, but they've just been completely intolerable, so they may have been very short trials, then this is when these other options become live. So if you have more than 4 disabling migraine days, but actually less than 15, we call you episodic. And these names, they are always frustrating because it's a chronic condition, but that's what we call you. We call you episodic. And if you have more than, 15 days of the month, and at least 8 of those being, with migraine, then we'll call you chronic. And it is important because if you are in the latter group where you're having a lot more headache days, then there is good evidence for Botox. But if you're not in that group and you're in the group who have, fewer headache days in the month, then actually Botox is not for you, but monoclonal antibodies may be. And obviously the key thing here is also to think about pregnancy. So if you're a woman, obviously, if you are thinking about imminent pregnancy, then I would pause and say the monoclonal antibodies are not for you at this point. So when you're taking these, the current advice, and this is probably consensus, there's no evidence base for this because we just don't have enough pregnancies that have gone through, but the current advice is you have to be on robust contraception and actually expect, not to conceive during treatment and for 6 months after stopping. So that contraception must continue. With Botox, because it gets out of the system much quicker, it's not so long after stopping Botox that you can start trying. So in terms of cranial Botox, it acts on the outside pain nerves and also the muscles. It's been approved by NICE. And, in essence, you get 31 injections, and we do them in very fixed places. And I'll show you on the next slide exactly where. And we can increase it if we feel that there's a need to do that. And you would come in and you would get 2 treatments. So there'd be 3 months apart. We'd do the first cycle and the second cycle, and then take a view of what benefit you've got. Now, NICE suggests that if you have at least your headache days have reduced by at least a third, but you're still having more than 15 days, then we can go on to continue and treat you for the year and then reevaluate. In terms of the evidence, well, I think when we're talking about, chronic migraine, we want to know what's the chance of my headache days reducing by at least a half. And after 2 cycles, if this was just this is just again our pool of 100 patients. If I gave you 2 cycles, we would find that it would be about a half patients would find their migraines improved by half. And if it was after 5 cycles, then we would find that, probably 2/3. So 1 and 2 after 2 cycles, 2 and 3 after 5 cycles. In terms of the actual targets, this is just a picture to show every dot that you've got. That is a target that we would go for. We inject the same volume everywhere using tiny, tiny little needles. It looks horrendous, but most people get through it, and they say it's much better than expected. I know many of you on the call may already be having this treatment, and hopefully you can share the word that it's not as bad as some people expect it to be. The side effects, they're infrequent. In good hands, I think they should be infrequent. The one that is more difficult to modify through how the doctor injects is whether you get a temporary headache worsening. We do see that. It is temporary, but it can be, it can be troublesome for some patients. Things that we have to just always be mindful of is this works on muscles. So sometimes the symmetry of the eyebrow changes, or you get a little bit of eyelid droop, or neck and muscle pain, and sometimes a change in bite. I have to say we've never had to stop someone before giving them the second cycle before side effects. And the side effects over time have improved because we've changed how we've injected. So when we first started injecting back in 2010, 2012, many people were getting a lot of neck pain, and that was because partly of how we were injecting. So I'm going to, next come on to the CGRP monoclonal antibodies. And for this, you need to, I think it's helpful to understand some of the basics in terms of how our nerves communicate, particularly our pain nerves. So what I'm trying to show you here is my diagram of a nerve. And it's a nerve that is trying to communicate with your pain command center. And there is a junction. And at this junction, this is where we have to think about CGRP. So if this is one of the nerves, it's got lots of this chemical, because that's effectively what it is, a chemical sitting in the nerve. And when electrical signals come down, which are how nerves communicate, then some of these will actually be released, and they'll be released into this space. And this is how it can communicate to the next nerve and send the message up to the brain. And these keys, they hopefully have a lock. And that lock is, I've shown you the padlock. And what you want to see happen is for those keys to fit in the padlock to open, and then the signals to keep on going through, and for your pain center to say, right, I need to sort of like amplify my pain system and switch on, and your migraine gets worse. Now, the new treatments are coming along, and what they're trying to do is they're trying to stop that key or that padlock from working well. So we've got 2, Agivy and Emgality, or fremunazumab and galcanezumab, and they are crudely trying to stick to the key and not allow the key to fit into the lock. On the other hand, we've got Aimovig, which is a bit different because it leaves the key, which is the CGRP, alone, and it actually goes straight to the padlock and blocks off the padlock, so the key can't fit in. And by doing that, effectively what happens is they're stopping all the pain signal communication to the center of the brain, and so the brain doesn't keep on in that cycle of ongoing pain. And we already know that things like the triptans, they're working, on this side at the CGRP. So different drugs, are all working on this in this area. And if I took you in the middle of a migraine, we find that the CGRP levels are high. And then when you find treatments that are effective, like the triptans or indeed these, then the levels become much reduced. So we've said that they're these monoclonal antibodies, and that bit is the bit where we use the immune system to go in and either target the key or target the lock. And currently for episodic, there is galcanezumab and erenumab, which are available. For emunazumab or Ajovy, it's nicer are looking at that one. And, I think give it, I think it's probably February or March that they will say you can use it for episodic, but it may take a little bit more time for it to actually be instilled in practice in trusts which haven't been using it for that. Whereas for chronic migraine, you've got access to all three. And I know I'm running a little bit over, but I will, obviously just want to spend a couple of minutes talking about these. We have 3 monoclonal antibodies in this country. What some of you will be, waiting on is eptinezumab, which is not on this chart, and that's because it's not available, but it is slightly different. But let me talk about these 3. What you can see is that they're all pens, and this means that they're all self-injector pens. They look a bit different because they're obviously different brands, but they all are doing the same thing. And the idea is that you would get monthly injections for 3 months, and then we would assess and see what your response is. And you would get for emunazumab and erenumab a single dose each month, and then assess. For galcanezumab, it's slightly different. It has a higher dose at the start, so you actually get 2 injections the very first time, and then 1 injections in the 2nd and 3rd month following. And NICE have set various markers as to when we can consider continuing these treatments after 3 months. And if you're episodic, and that's those who are having less than 15 headache days before you start treatment and at least 4 migraines, then you will need to see a reduction in your migraine days by 50%. So if you're someone who's having 6 migraines in the month, we need to see that that drops to at least 3 migraines in the month to continue this. And those who have chronic migraine, because it's a more difficult condition to change, they've accepted that if we see a 30% improvement, then that's enough to continue treatment. And we would automatically continue treatment for a year. And then I put then ... because I think different places are doing slightly different things. Now, what I should say, I have more limited experience because these have been in this country for a shorter period of time, but certainly my reflection is we see some patients who respond very quickly, certainly within the first couple of weeks, and then we see those who really don't see any improvement until that 3rd month. But we feel that, hopefully by 3 months, we'll have a good idea if this treatment is working in you. Those people who have that slow onset of response, definitely, over the next few months, we're expecting that response to improve beyond where you are at the 3-month mark. So that's just to say. And I said, at the end of the treatment year, what do you do? Well, I think it's a question of, do we give you a pause to see whether your migraine is still very active under all of that? And I think, certainly in my centre, that's what we're doing, but it's not a long pause. It's just really right, let's just try and extend, the treatments to see what happens in between. And if you get a big flurry of migraine, then you get straight back on and continue treatment. The chances of your migraine days reducing by at least a half, according to the trials. Well, if I first of all show you just the effects of effectively giving you a salt water injection, what you can see across them all is that there is this placebo response. But what you can hopefully see is that with the active treatment, the response is much bigger. Emgality here looks perhaps a little bit more impressive, but you must remember that the placebo response here was much bigger already. So I think it's fair to say that in the patients who have episodic migraine, and sorry, the data I was showing was just for those, there's a 50% chance that you will be or have a halving of your migraine days. So that's pretty good. For chronic migraine, again, I'm just showing you what they saw in the trials that use the salt water injection. If you then looked at the patients who had the treatment, again, you see sort of like a variability of 30 to 40% who will see at least a halving of their migraine days. Now, I would emphasize that is quite a hard task point to meet. And in chronic migraine, we don't set it as a 50% improvement. We set it as 30%. So actually, substantially more patients will be continuing on this than the 30 to 40%. In terms of side effects, and these are just the last couple of slides, then obviously probably the commonest thing is the injection site issues. And these are transient, so they'll last, hours to a number of days, but they do generally just disappear off their own with no intervention. You can get a little bit of redness or itching at the site that you inject. Around the area, you can get some lumps and bumps. It can be a little bit raised and red. But as I said, that's usually all that happens, and it just resolves. Sometimes taking an antihistamine may offer some benefit if you're one of those who has that repeatedly. Also using things like a cold pack before you inject may modify it, although that's just sort of like my experience rather than evidence-based. The other side effects are constipation, but constipation has been mainly seen with iralimumab and galcanezumab. And it's not to be, underestimated, because certainly constipation, if severe, can cause people to go to hospital. So that's obviously what we don't want. So always get on top of it, make sure your bowels are good going into it, and keep, your diet healthy with lots of water and fruit and fiber. Dizziness was reported with galcanezumab, not with the others, and hypertension, new onset or worsening of hypertension, was reported with iralimumab. But the numbers in which these have been reported are very low, so it is not something that we're seeing significant side effects from. Hypersensitivity reactions, itch, or evolving to urticaria, which is like hives over your body, has been reported, and I think that's across the group. And there's always that very rare risk of having a more allergic response to these medicines, but that is also the same with other medicines that we use day to day, like penicillin. In terms of what I've shown you, I've focused very much on the trials, because that's allowed us to get these medicines into the clinics. And some of the real world reporting of side effects, it does echo what we've seen in the trials, but there's been a few other minor readouts. And, I think we've touched on many of them. Some people have reported feeling cold and flu-like. Certainly in my clinic, that's not been a report. Fatigue is a difficult one, because actually with migraine, fatigue can wax and wane. So I think it's been reported, but whether it's directly the drug or not is unclear. Muscle spasms, I think that was seen as a side effect with one or two of the monoclonal antibodies, and it is a very low percentage. And the other issues, well, it's always difficult to know whether it really is the drug or not. And the final slide I just want to remind you about, because we're in the preventive section, is about the GPANs. And we said about the fact that these may offer us a new avenue of acute treatments, which can actually have a preventive action. And so with that, I'm going to stop. I'm sorry for going over time, but I wanted to try and cover as much as possible for you. So Una, I will hand back to you if I stop sharing.
Thank you, Jane. That was just fantastic. It was so comprehensive, and particularly because migraine changes over our lifetime. So you can go, you can be episodic for several years, and then you can chronic, and it particularly happens for women in their late 30s, 40s, and then you're episodic again. So it's really useful to find out, for people to be able to find out the different types of treatments at the different stages. So thank you for covering that. It was also really interesting to hear about actually how CGRP antibodies work. That was really interesting. So
I hope I didn't bore people with the with my attempts at explaining the science. It's complicated, but actually there is a very I always like to think of lock and key, because I think that helps you.
No, it's brilliant. And also because in some ways, I always think people with migraine, we're our own research, we're our own scientists in terms of our own body, knowing how our migraine works in response to things. So there's been a lot of different questions. And first of all, I'm going to ask them about eligibility, because there have been some questions about age. So, what are the cutoff periods for, at the upper end, but also in terms of teenagers? So that there was one man whose son has migraine that's very, very hard to treat. So what should he do? But then also you'd mentioned about pregnancy and CGRP antibodies. So what should someone do if they can't, if they're unable to take some of these treatments? So that would be good to know.
So I think that's always an important one to ask. So in terms of if you're young, then all the trials looked at patients who were over 18. So if you're in the younger age group, there are trials that are underway, and we will hope to be able to know with you've got to keep your eye on what's out there, because there will be trials emerging to say, are these newer treatments things that we could use in younger children? I think in the younger cohort, what we've found is that actually some of the behavioral strategies sometimes do much better than the drugs themselves. So I think don't be frustrated. I think start with the things which we know can work. Some of the oral treatments you can obviously use in the pediatric group, and then keep your be aware of what's happening. Get your child, if it's a severe migraine, refer them up to a centre who's treating children, because a lot of these treatments sometimes they are we enable access at an early age. For example, 16 to 18 is a very unclear age group, because you're sort of an adult, even though sometimes you're in the pediatric services. And I think that's one thing to do, because I certainly, if I've got someone in front of me who is physiologically grown up, then that's when we may bend the rules and start things earlier, with the patient's full awareness and consent. If you're over 65, then I think there can be some variability, and I hate to say it in this forum, but the trials, a lot of the trials did have, they do tend to go from 18 to 65, so it's a natural cutoff. And I think you're looking for significant concerns. So there's been quite a few studies which looked at people who had vascular issues, and obviously as we get older we get vascular issues, and that is the concern with some of these treatments. And they look reassuring. So although I wouldn't treat you with a CGRP monoclonal antibody if you've had a heart attack, actually if you've got blood pressure that is well controlled, we've got some evidence to suggest that these treatments are safe. So if you are a biologically fit 80-year-old, then your doctor, and that's your specialist, needs to take that on board and have a conversation about the risk benefit. And it's the same with the triptans. So many of you will have had that conversation where triptans are so useful for you. For me to say, oh, I'm sorry, you're 65, let's stop it, that is just not something that many of you can entertain. So it's that conversation. So that's that. And then pregnancy, I think it's tricky. So with pregnancy, I think these newer treatments, we don't have information, so it's just a no-no. With Botox, I think we do have patients who are trying to kind of switch on their activity, very much in line with, I usually say 8 weeks post-Botox, that's when you can try and get going. And if it doesn't work, then we will, review at the time that we would normally and treat, and we can work with that. We also use blocks, so we use cranial nerve blocks during pregnancy and during the time that you're attempting to conceive. So I think there are other options. And I didn't talk about blocks at all, because we think of them very much as a patch. So they're kind of a patch whilst we're getting the preventatives on board. But certainly in those groups who can't access these, then they have a bigger role. So yes, I think those are the things that I would think on. And don't forget the oral medicines. I know, it feels so disheartening when you think, oh, I'm back on the tablets, but some of them do work. And we've had people who are turned around and never get to the CGRP monoclonal antibodies, even though they're on the list to go for it, because some of these oral tablets do work.
Thank you. That's very reassuring for people who may fall out of some of the categories.
Yeah.
There's also been some comments about CGRP monoclonal antibodies, how effective they've been at treating people's migraine, and it's been life-changing for them. But some people are being told now that after a year they can't take them anymore. Where there's one person who's been on them for 15 months, and it's been very effective at treating their migraine, but they're being told that the NHS would only pay for a year. So and then I know there's a rule after a year, which would be good if you could explain that to people.
Yeah.
What should they do, and how should they talk to their specialists if they're being told that?
So I think there is no mandate that you can only have a year's treatment. So I think that's the first thing. I think there are some open-ended things, and that's partly because, and that's good because, as a clinician, I want to be able to help you to the very best of my abilities, but I also want to be able to show that this treatment is still needed. So if I forget the CGRP monoclonal antibodies and think about one of our oral treatments, we've got evidence out there to say that actually, if we are able to switch off your migraine state, then if we keep it switched off or really switched down, that's what I really mean. If we keep it like that for 6 months and stop the treatment, you won't, there's a good proportion of you that won't bounce back. And that's the idea of, well, what do we do after the year? Because we are seeing some patients who respond, exceptionally well. And what we're really wanting to do is just test the water. And I think sometimes it's about how we explain it to you. And I've learned, so, I've set up my service. I did bad things at the beginning, and I've hopefully corrected them. So at the beginning, I was saying, right, we're going to give you treatment for a year, and then we are going to stop. But I didn't make it clear why we were stopping. And also, what my experience has been is that when you get to that 12th month, that last injection, you get so anxious that your migraines just increase anyway. So now in my service, if you are on the monoclonal antibodies and you have chronic migraines, so we're expecting a potential high frequency bounce back, you will have an injection that's in your fridge waiting for us to just see when is the right time to restart. And I think, we're doing it in different ways. Some centers are saying, well, let's step it out and see if you can go 4 months rather than to go 2 months rather than treating it a month and see what happens. So I think centers are doing things in slightly different ways. And I know as a patient that doesn't always help, because you'll hear one center where I've said that you can have ongoing treatment if we demonstrate that it's needed. And then clearly somebody out there is being told that they've got 15 months and that's it. So I would go to your doctor and really say, well, what happens if my migraines, start picking up? How quickly can I expect to restart treatment? And I think, I would actually phrase it in that way so that you can get the reassurance that you can restart if things pick up.
Thank you, that's very helpful. And we've also had questions about Botox. So there's one person they've been having Botox injections, which has reduced the frequency of their migraine attacks. But what is the measurement to assess if it's considered an effective treatment?
Yeah.
And there was also another question about, is there anything that can be done because it's not great, having all of these injections in your head, particularly for someone who gets migraine, can be quite daunting. Is there anything that can be done to reduce the pain of receiving the injections?
Yeah. So I'm going to tackle the first is what is the outcome measure that we use? And in some ways it's a little bit difficult because NICE, who fund these higher cost drugs or who make the agreement that they should be funded, has set certain cutoffs. And the one for Botox is actually the number of headache days. And we're looking for them to reduce by at least 30%. Now, we do occasionally have patients where actually the headache days don't reduce by 30%. But what happens is the headaches go from being, 8 out of 10, so very severe, to being mild. And actually that's completely transformative. So that's when, that's when the clinician needs to work with the patient, work with the people who commission the drugs, and to find, the best solution that they can. So, this is when I would be going back and saying, well, look, I know that we're not meeting that outcome, but that patient has done exceptionally well. So, can we consider, treating further and seeing, in another 3 months or in another 3 cycles where she's at. And so that's the conversation we'll often have. For some people, we found that actually headache is not the most bothersome symptom. So if you get, vanishing of, nausea, which, certainly I've seen a lot of, if that nausea and vomiting stops, life is very different. So I think we've got to take it on an individual basis. There are some outcome metrics that we've got to try and achieve, but we're thinking about you as a patient. And if overall your quality of life has improved, if we can capture it in some way that we can communicate to the people who fund it, then they try and work with us. The next point, Una, I've forgotten the question already. I'm trying to think.
The pain
of
the injection.
Yes, sorry. So I think the pain of the injections, I'm always trying to make sure that our techniques are as good as possible, that we get you to do relaxation techniques before you come to clinic, that we don't keep you waiting around in the clinic, and we try and identify those of you who find it even more difficult. We have a few patients who will actually take something like ibuprofen before they come up to clinic, particularly if you've got fibromyalgia or very, very tender muscles in your neck and shoulders. Using things like cold packs, actually, applied to the areas which are really painful, can be beneficial. And talking to your doctor, we're there to help. We don't like it when you find it painful. We know that we can't take it away, completely. We have some patients who absolutely, they want the worst last. And sometimes the worst is the front for some patients. So in those patients, I will start at the back and work forward. So it's that, talk to your clinician, and we will try and do everything that we can to make it a bit more bearable.
Thank you. That's very useful. And there have been several questions about triptans, and particularly probably concerns about using them. So there have been questions about how, what are the maximum amount that you can use during a month, but also the long-term side effects, such as to the liver and to blood vessels. And also someone had a question about if they've been taking one triptan, they've been prescribed one, they don't think it's working. How do they talk to their doctor about being prescribed another?
So in terms of triptans, long-term effects, I have to say that I don't worry about long-term effects, providing we're not sort of like using it on 30 days of the month. So really, triptans, my advice to everyone is to keep it down to 8 or less if you can. And I, generally speaking, try and ration myself. I'm a triptan user, so I ration myself, and I think it works for me. So I share that. So, I'm getting people to think about on a week-by-week basis, have 2 days that you can treat, and if you go over that, then you need to think about, is there a different way of managing that migraine episode? And if you don't use those, then actually, if you're in that last week of the month, you could use it every day if the migraine warranted it. So that's one thing. So long-term side effects, I don't think we need to be worried about. Effects on vessels, I think this is a theoretical concern, but it's enough that if you've had a vessel event, and by that I mean a heart attack, a stroke, or some other, stroke to some other place, then we would say, you shouldn't be using them. But the evidence that that's based on is small. It's about the theory of these being on blood vessels and actually acting on them. And I think it's not, there's a concern that they could cause constriction of the vessels, but actually with things like the CGRP monoclonal antibodies, it's not the constriction. It's more the fact that when you have an injury, sometimes the vessels have to respond by getting bigger. And, there is a concern that perhaps it stops that vessels getting bigger that you need. So that's why we are, not using it in those patient groups. In terms of how you have the discussion with your GP when a triptan isn't working, I think, what I was trying to outline is if you go with having, asked yourself the right questions and actually say to your GP, I always set out in my letters that if a triptan isn't working on 2 out of 3 attacks, then it's worthwhile trying a different one. So that's one thing. And by working, we use the 2 hours. So, 2 hours pain-free, fantastic. The reality is that some of us will never get that. But 2 hours, if you get a really meaningful reduction in pain, then that's a good response. But you should be able to say to your GP, look, this is, helping me, to a degree, but I do want to see if there's something better out there. You need to emphasize to them if the headache is coming back, because if it is coming back, then some of the triptans are better at trying to stop that comeback. So for example, sumatriptan, you may well get this comeback, which is the rebound headache, a number of hours after taking it. So you're always having to reach for something after it. Now, you could say, well, why can't I try one of the ones that acts a lot longer, like naratriptan or almatriptan, because it may stop that. So it's about having, being armed with why the triptan that you've got isn't as good as you need it to be.
Thank you. And there was just one more question about triptans. Can you take them with antidepressants?
So yes, so there was this idea that you could have a serotonergic syndrome. There is, again, one of these theoretical concerns. We've had hundreds of patients who are taking antidepressants and triptans, and the reality is that serotonin syndrome, we are not seeing anything above the baseline risk. So yes, you can take antidepressants, triptans, and you can take them with the CGRP monoclonal antibodies. So please don't worry about that.
Thank you. And we're just coming up to 11, but is it okay if we run over for another 10 minutes? Because this remains a different question. Brilliant, thank you. So there have been a few questions about different, particular types of migraine. So what should someone with vestibular migraine, hemiplegic, and also, it's not migraine, but hemicrania continua, what would be the best options if you have those three conditions?
Okay, so for vestibular migraine, I think, it is about treating the migraine. Obviously, the vestibular symptoms from a symptom perspective are awful. And, do we have great treatments that are just targeted to that? No. But the point with vestibular migraine is, you've got your pain center and it's extending to different areas. We already know this for everyone with migraine because we get the light sensitivity, the sound sensitivity, and that's because it's reaching to different areas of the brain. For vestibular, is really reaching to our balance system. So the idea is if you could control that, command center, that pain center, then it would stop reaching out. So bottom line is, with all migraine, you need to treat the migraine using the drugs that treat migraine. In terms of vestibular migraine, there may be a place for things like vestibular rehabilitation, which is physiotherapy trying to get the brain to adjust to this hypersensitized balance apparatus, if you like. There are also certain drugs which there's, I can't say the evidence is compelling, but my personal experience is there's certain drugs that I like to think about using. So one of the drugs, flunarizine, is not licensed in this country, so you tend to have to go to specialist units. But there's a little bit of evidence to suggest that in patients who have vestibular migraine, it can be very effective. It's a very effective migraine drug, full stop. So if you're in Europe, actually, you can access this without any bars. But I think I tend to like flunarizine and sometimes even go back to pizotifen, just based on more my personal experience and also some experience from colleagues. But you're going to treat the migraine. Hemiplegic migraine, that's a whole talk in itself, in part because there was always this concern that with hemiplegia, you can have there's a greater concern that you could have problems with the vessel supply. So we have, originally we would say you could not use triptans, and all the drugs which had that concern about them affecting the vessels, we less wanted to use. I think you need to be in a specialist center if you have true hemiplegic migraine, because there are decisions that we can make where you are involved in the decision making, and we can actually tailor it to you. I would say, however, that the people who have what I consider to be true hemiplegic migraine is quite a small group. Many people feel that they have hemiplegic migraine because they feel they can't move one side of them during an attack, but that sometimes is not actually what we think of as hemiplegia. It's driven by the fact that actually your sensory changes are such that you think that side won't move. So it is a very small group. And again, there's every importance in getting the right label, because otherwise you will perhaps not be using very effective treatments. And so that was the vestibular, the hemiplegic, and there was one other. I'm terrible today.
And the headache, just sort of hemicrania
continua. So this is one of the ones which is in a slightly difficult camp. It's one headache condition that is exquisitely responsive to indomethacin, and we use that to actually often make the diagnosis. So it's effectively having what feels like a migraine, but it's all just on one side, and it is continuous. There's no let up, and you can have sometimes watering of the eye on that side, or puffiness, etc. And I think if any of you have headache that's just on one side all the time, it never stops, always make sure that you have had a discussion with your doctor about whether you should try indomethacin, because occasionally you get a surprise and it just stops. But the problem with indomethacin is it's quite irritating on the gut lining. And if it is, that really limits how much you can use this treatment. So the treatments that we tend to think of are, again, a lot of the migraine treatments, because there is an overlap. Topiramate is probably my top one to go to, thinking about blocks, and we will consider Botox in that group, and there is some evidence to suggest that it's helpful. The problem with things like hemicrania continua is very rare, so the amount of evidence out there is still very small.
Thank you. That's really, really useful. And just the last few questions. So there've been quite a few asking about migraine and the menopause, such as, does HRT, is it useful, or what are the best things to take at that?
Yeah. So I think it's a really difficult time, full stop. And I think, migraine, we often see it being very active, and not just for, I think when, naively, some people think of the menopause, they think, oh, it's going to be 5 years where life is going to be tricky. But my experience with headaches is that they are unhappy for a lot longer. So I often say, when you think the menopause has started, wait 10 to 15 years, because actually then you may find that your migraines do improve substantially, because post-menopause, and properly post-menopause, they can. Managing it during the menopause, well, I think firstly, think about the other symptoms of menopause, which may be winding up your headache state even further. So insomnia, anxiety, all of these will feed into your migraine pain. So you've got to try and manage those. HRT, I encourage women to think about using it if they're using it for the other symptoms. There's no good evidence that HRT just for the headache works effectively. If you're getting all these other symptoms, then definitely you should be using it. Patients often are concerned if they've had migraine with aura, because we're always saying, don't use estrogen, don't use the oral contraceptive pill. And actually, what you're trying to do with HRT is give you back what your body is not giving you. So you can have HRT even if you've had migraine with aura, if you're in that, menopausal period. Yeah, that's probably all I'll say on that.
Thank you. And then a final question. There were a few comments and questions about riboflavin and Q10. Q10, how people have found it very useful, and just do you have any advice or anything that you'd like to say about that?
So sorry, because I didn't put that on the list of drugs, and I do use it. So riboflavin, 400 milligrams, taken once daily. Do it for at least 2 to 3 months, so that you can see what effects it would have. It can turn your urine a very peculiar color, as many of you will know, but I think it's definitely worthwhile trying. We do have patients who respond to that. The trial was small, and that's often why it doesn't enter in on some of the slides. So when trials are small, we don't always know that we can trust the evidence, if you like. But it was very encouraging. So, you saw over 50% of patients feeling that it was improving their migraine state. And you can buy it at Holland and Barrett. I'm sure you can buy it at Tesco. It's 400 milligrams. It's 400 milligrams. So sometimes they sell it as 200 milligrams. Just take 400 milligrams a day. Coenzyme Q10, likewise, I am happy for patients to use it. It's probably, I recommend that, if they're going to just stick with one, they go for riboflavin, but if they want to try more, then definitely coenzyme Q10. Magnesium, some people can use it, or some people may want to try it, and definitely you can. I think the evidence base, there were a few slightly conflicting small studies, so we don't really know how effective it can be. I would say with magnesium, just be aware that you can end up having some changes in your bowels, and they can get quite loose. So with magnesium, you may find that you need to start on a slightly lower dose and then build it up just to see what helps.
Well, thank you. And thank you for a fantastic presentation. It was incredibly informative and comprehensive. I've learned, I've been working at the Migraine Trust several years. I've learned several things from it. And I hope everyone who attended today, and again, thank you to everyone who came along and asked questions, but also you shared your experiences of migraine. I really appreciate that. And it helped really draw out some of the key issues when it comes to taking these medications. So thank you, Jane, but also thank you everyone who came along. And if you feel that your question wasn't answered, you can also go to the Migraine Trust website, which is migrainetrust.org. We also have a helpline that's open from 10 a.m. to 2 p.m. Monday to Friday, and the number is 0808 802 0066. And the number is at the top of the website. And there's another event starting shortly, but we'll be running more of these events throughout the year. And we hope you found it useful. And thank you very much. But most of all, thank you, Jane. That was just really just a fantastic presentation.
Good.
And so just thank you for your work that you've been doing for years in helping people with migraine. So that in it, not just today, but just what you've been doing for your career. We really appreciate it and your dedication from everyone with migraine.
Thank you very much, Una. And I would say that my conversations with all my patients is to signpost them to the Migraine Trust. And I think if any of you have just come onto this and haven't actually had a good look at what they can provide, I think we are very lucky to have a very powerful, patient advocacy group and a resource of, great information. And I think when you're feeling lonely, you should always know that actually there are many people out there who are experiencing what you are experiencing. It's just being able to connect with them or connect with the information which makes you aware that you're not alone.
Thank you. And I would echo that. That is, you're not alone. 1 in 7 people live with migraine, and we're a strong community, but we need to work together more and strengthen ourselves, that's for sure. But there's also a lot of hope. Things are getting better in terms of treatment, but people like Jane are leading the way. So thank you very much. And thank you to everyone. And I hope you enjoy the rest of the weekend.
Bye. Thanks for your time, everyone.
Thank you.